So let's talk about the biceps tendon. So as you all know, the biceps tendon, the long head, comes from the biceps muscle up through the intertuberous groove where the transverse ligament kind of holds it in place over the top of the humeral head and then attaches primarily to the superior glenoid right above the superior labral attachment, but there are also little strands that go around the capsule anteriorly and posteriorly. The short head, as you know, comes up to the coracoid process. So here's some very early T1 weighted images when we were trying to look at the biceps. There we can see the biceps going over the shoulder. Obviously, how well you see it longitudinally in the coronal plane depends upon the rotation of the humeral head. If it's cranked around a lot, you can see it like this. Be a little bit careful when you get into its attachment. There's usually a central attachment that's very prominent here, but you can have these little strands off to the side, and don't call those partial tears when they're nice and smooth like this. You may or may not see a little high signal line between the biceps anchor and the superior labrum. There are more or less attachment between the two, so that can be very variable. And in the sagittal plane, I used to use this plane a lot in looking at the biceps. The biceps anchor is right up here. Here's the superior labrum. Then you can follow it out. Here's the cocoacromial ligament coming across there. And then if you follow it out, you can see the biceps here. A little bit of tendinopathy in this one, not much. Coming down here. And then the next cut would actually, it would dive down into the intertuberous groove and go out into the arm. The axial plane, as you all know, is a nice plane. Biceps should sit deep inside the well like this as you go up. And as you all are very well aware, and we're going to go over it again, subluxation of the biceps is a common problem. You can get a lot of traumatic arthropathy within the tendon due to its rubbing against the coracoid process here. And then we'll talk about where it dislocates later. We saw a previous case like this. Here we don't see a biceps tendon in this particular person. And if you follow it up, there's no biceps, but also if you get up to the top of the joint space here, there's really no intertuberous groove either. So this is what you see in congenital absence of the long head of the biceps tendon. And you don't see it in any of the other planes either. That's pretty rare, but I think we've seen one so far since you guys have started the fellowship. Okay, let's start. Let's see, who's next? Greg, are you next?
Sure.
So,
27-year-old female professional volleyball player with shoulder pain. So we have an axial view. Looks like there's two hypointense structures, one sitting within the bicipital groove and another similar structure kind of anteromedial to that. I would assume one is at least the biceps, long head biceps tendon.
what are these things here?
I'm not sure what those are.
Those are called vincula.
Vincula.
Most of the time we don't see them, but these are fibrous connections between the biceps tendon and the synovial sheath there. Again, this is in the joint space. This is not really a tendon sheath. This is part of the glenohumeral joint space here. And this synovial lining here is contiguous with the synovial lining of the joint. And when you see that, you know that these are both tendons, and this is a congenitally bifid tendon in this particular patient, with one a little bit subluxed anteriorly. So that's a congenital bifid with biceps. Pretty unusual. Okay, Robert.
All right, so we have a 43-year-old with shoulder pain. Looks like she's externally rotated. Yeah. See the biceps there, looks pretty good.
See this thing here?
Mm-hmm.
You don't see it so well in through here.
Right.
So the question really is, what is this? And what is this thing up here anteriorly?
Did you say the biceps is pretty good?
On that first image of the
That's what Robert said,
Mhm.
but we're gonna dispute that in just a minute here. Okay, so there are two structures here
Mhm.
that, this could be anterior labrum, but we followed up here, that doesn't, the labrum is really displaced.
Mhm.
But what we're seeing here, this is an anterior dislocation of the biceps tendon, which we'll talk about. And this is a confusing little thing that's actually commonly seen if you look for it.
Mhm.
This is the accessory head of the biceps brachii. And the difference between the two is this is a little fibrous band that's connected to the kind of the capsule here, and this inserts with the capsule on the humerus, whereas the long head of the biceps inserts on that superior tubercle of the glenoid. And you can often see both of them in the joint, and this is considered a normal variant. In fact, if you look for it, you'll see it most of the time. So this, you can't be confused then by an accessory head of the biceps when you have a big dislocated, anterior dislocated long head of the biceps, but we'll go through that dislocation. So this is just kind of a diagram of the accessory head. It comes up here, it's a thickened fibrous thickening, really associated with kind of the capsule margin here, and it inserts on the humerus, whereas the long head of the biceps goes all the way through the joint space and inserts on the glenoid. And this is just what it looks like kind of histologically. There's the accessory. Here's the biceps itself. Again, you can see how this accessory is usually more flattened and is really associated with more with the synovial sheath there. And this is the actual biceps itself, which can be surrounded by joint fluid. The accessory is usually not surrounded by joint fluid. And here's just an example where you see both and the same. This is not a bifid biceps. This is an accessory with a long head intact. And this just shows some, we don't need to go through all this, but again, this just shows how that accessory is really associated with the capsular there. Some people call it aponeurotic expansion. They're like we were just talking about. There are a lot of different words for kind of the same phenomena. Some people try to split them out as different, but again, this is just another thing that looks a little bit like the biceps tendon, but it's really associated with the capsule there and is not surrounded by fluid anywhere. So that's the accessory. And again, it's a pretty common finding. Here you can see it again. And notice the biceps is surrounded by fluid. This is that accessory biceps or aponeurotic expansion, depending upon how you want to. Yeah. And then you can see where the biceps will go across here, and the accessory will fuse with the capsule out through there. Here's the biceps coming across there. Okay.
All right, 4-year-old female, right shoulder pain, 3 weeks. So I see some traction edema, 32 tuberosity, and then there's kind of attenuated superior, supraspinatus, and then, is there a tear of the biceps anchor?
Funny thing in here, right?
Yeah.
So here, if we look at a bunch of different images, you can see the supraspinatus there. There's the superior labrum, biceps anchors coming in through there. If we follow it out, it comes out. And this is just in this particular patient where they did arthroscopy here. And this turned out to be a split tear of the linkage of the biceps tendon with adhesions of one of the split tears to the capsule in through here. And this is not an accessory bicep. Why is this not an accessory biceps? Again, we see these two black lines coming here.
Well, the accessory doesn't go intra-articularly, right? It doesn't.
Right, it attaches over here to the humerus, not to the glenoid. So this is part of the long head of the biceps, and we have basically a split tear. And there are a number of different criteria where people have categorized different anatomic variations here. Again, I'm not going to go through this in detail because it's not something we commonly see with MR. Okay. Okay, so looking at the biceps here, it looks irregular anteriorly. Yeah, some kind of, and here we can see maybe a little thickening of that capsule, maybe a little accessory there. We have some funny signal in there. And a little signal going through it here. And then here the one cut of the sagittal images. Forget the supraspinatus tear. This is the biceps. What do you see here?
It looks like a split tear.
Yeah,
Yeah,
right in through here. So that's a longitudinal tear within the biceps.
a longitudinal, yeah.
And just remember that one of the most common injuries of the shoulder, which we see every single day, are these anterior insertional tears of the supra. Whenever you see that, you have to look carefully at the biceps because it's often associated with biceps disease and with disease of the superior insertion of the subscap, which we've talked over and over again. But it's a common lesion and it tends to be very symptomatic. And if you don't treat all three of those lesions, it's less likely that the patient is going to get better.
Okay, so we have two coronal views here. I can see in the first, I can see part of the biceps tendon distally, more proximally within the intra-articular portion. Looks like there's some increased signal throughout the tendon. So I don't think there's a tear there, but
There's the axial, one cut axial, another cut. What do you see here?
so it looks like there's some kind of irregular signal centrally within the tendon.
The margin's a little bit indistinct over here, and it's perched on the lesser tuberosity. It should be deep in the well here. This one is anteriorly subluxed. A lot of people call this perching. And if we go farther up here, now we're seeing a lot of increased signal intensity within it, right here. Here we don't actually see a black structure like we should coming across there. And this is kind of severe biceps tendinosis. And you can look on the different fat suppressed images and determining how severe it is. If you think it's really severe, you might call it a partial tear. The bottom line is, as you've heard me say over and over again, I believe that these tend to be very symptomatic. And it's something that really, if the patient goes to surgery, it can't be ignored. So if we look at the anatomy here, again, we've seen a little bit of this. Here's the short head of the biceps coming up to the coracoid process. Long head goes across the transverse ligament here, which is continuation of the superficial fibers of the subscap. Underneath the supraspinatus and the coracohumeral ligament across there. Here we can see the different anatomies, and this just shows the forceps in here, long head of the biceps tendon. This is that transverse ligament, and that's the tunnel that the tendon goes through in the intertuberous groove going up, and you can see how this transverse ligament holds it in place. And again, the transverse ligament is really part of the superficial fibers of the subscap. So if you start tearing the distal subscap, you're likely to have an injury to that transverse ligament as well. And that's why I think there's a close association between displacement of the long head of the biceps tendon and superior subscap distal insertional injuries. And this is the coracohumeral ligament coming across here that we'll talk about. And this just shows that supraspinatus retracted up, and here's where the biceps would go underneath there. Okay, and then the superior glenohumeral ligament we talked a little bit about the other day. This comes under, wraps underneath and around the front of the long head of the biceps tendon, and then attaches over here on the glenoid anterior to the biceps anchor, and this helps hold it so that it doesn't anteriorly sublux. Superior glenohumeral ligament, there's the coracohumeral ligament. And just kind of shows the anatomy and with the different layers in this area. Okay. I think I might have showed this before. This is just another diagram, more from a radiology standpoint. Long head of the biceps coming here, transverse ligament. And here you can see that superior glenohumeral ligament attaches to the glenoid, and it's just anteriorly, a little bit inferior to the long head of the biceps insertion, folds underneath it, and helps hold the biceps in place so it doesn't sublux anteriorly. And on the sagittal images, this is kind of the way the two are associated with one another, right in through here. So, and then here's the coracohumeral ligament coming across on top here, long head of the biceps tendon. So here's supraspinatus over here, supraspinatus, coracohumeral ligament here, long head of the biceps there. And then, again, just other diagrams of this same anatomy coming across. So here's the biceps anchor up here. Here's the superior labrum right below it. This is the biceps anchor of the sagittal plane. Come farther out, here's the biceps, coracohumeral ligament, superior glenohumeral ligament underneath it, which helps hold it in place. This is an arthrogram. We go farther out. Now we're kind of beyond the superior glenohumeral ligament. And
that produces a sling, right, John?
right. And and then we can follow it all the way out. And it's diving into the intertuberous groove at this point. And here's a case where you have a superior glenohumeral ligament tear, and you've got anterior subluxation of the biceps tendon with a tear of the superior glenohumeral ligament. So it's just a cartoon diagram of where you can get the tears of the ligament. Here's a normal, everything in place. But when you start getting tears of these supporting ligaments, then you can start getting anterior subluxation of the long head of the biceps tendon. So this is that grading system that we used back when I was in Santa Barbara many years ago, back in the 1990s. Which I did not publish, but a little bit later in arthroscopy, Bennett came up with a kind of a similar but much truncated grading system that I'll go over in just a minute. But let me go over the one that I used for a while. This is where you have a sling injury without displacement, and therefore you can see a superior glenohumeral ligament tear without actually displacement of the biceps. Best seen with arthrography. Grade 1 is you have a perched biceps. Grade 2 is displacement of the biceps into the subscapularis tendon. Then it can cut through the deep fibers of the subscapularis tendon into the joint space. And in the early 1990s, I was quite confused with some cases we had where it looked like we had the long head of the biceps tendon displaced into the joint space, but the subscapularis tendon looked like it was intact, which how could it get from external to the subscapularis tendon to inside the joint space with still an intact subscapularis? And we'll go through the solution to that dilemma in a minute. And then you can also get displacement about 15% of the time, about 85% of the time. It'll end up into or deep in to the subscap, and I'll explain why in a minute. And then you can also get it displaced anterior to the subscapularis, which is less common, only about 15%. You could get dislocation of the biceps with a subscap rupture. And then the rarest of all is a posterior dislocation of the biceps. I'll show an example of that, but these are, I think there are only 3 or 4 in the literature. And then you can get a complete rupture of the biceps. Nobody uses this, but to me, that's kind of the progression of disease of the biceps tendon. So the most common grading system that I'm aware of in the orthopedic literature is from Habermeyer, which came out a year later than Bennett's and JSES in 2004. And the type 1 is where you have a superior glenohumeral ligament tear with a perched biceps. Type 2 is a superior glenohumeral tear with a supraspinatus tear. Again, these are superior insertion of the subscap and the anterior insertion of the supraspinatus, like we've been talking about. Type 3 is a superior glenohumeral ligament tear and a and the subscapularis tear. Sorry, this is supraspinatus, superior glenohumeral ligament. And then type 4 is superior glenohumeral ligament tear with both of the others torn. So obviously the common thing here is you can't really have biceps instability without a tear of the superior glenohumeral ligament. This is a surgical grading system where you can see the superior glenohumeral ligament much more reliably at a arthroscopy than we can see it at MR. And type 3 and 4 are much more closely associated with anterior superior joint pain. So this is just that classification. Here's a normal anatomy where we have subscap, supraspinatus, biceps, and the transverse ligament there. This is the superior glenohumeral ligament. And then here we have, which comes around and attaches anteriorly. Here's one where you have a tear of the superior glenohumeral ligament with the other 2 intact. Here we have a tear of the superior glenohumeral ligament here with a tear of the supraspinatus tendon. And now we're starting to get anterior subluxation of the biceps, perching of the biceps on the lesser tuberosity. Group 3 is where you have anterior perching of the long head of the biceps, maybe extending a little bit into the subscap with a tear of the subscap. And here we have a tear of the superior glenohumeral ligament, tears of both the supra and subscap, and dislocation of the biceps tendon into the subscapularis tendon. Then what happens is this tendon is now located in this tear of the subscap, really between the subscap and the bone. The forces pull the tendon this way, medially and posteriorly, and so what it does is it causes the tendon to tear the biceps tendon to tear the deep insertional fibers of the subscap. Then it ends up here. These transverse ligament and superior fibers stay intact, and then the subscap can re-heal back down to the bone, and therefore you can be left with a intra-articular biceps tendon with an intact subscapularis insertion. The big dilemma that we futzed with for a couple of years before we understood it. Sorry about all the motion here. Here we can see a little bit of perching of the long head of the biceps tendon, and here's that partial tear of the subscapularis right here. And what happens is the biceps tends to sublux into the tear and then back again. Depending upon the way you position the shoulder at the time of imaging, you may either catch it in the subscapularis tendon or back at its home base, back in the intertuberous groove. But what this indicates that it's actually moving back and forth, and you have an unstable biceps tendon. And once you have an unstable biceps tendon, it's likely to be a cause of shoulder pain. Okay, so here we can see in this particular case, here's the coracohumeral ligament up here, biceps tendon, and this is the one that's subluxed a little bit, and we can see the superior glenohumeral ligament is very abnormal in signal intensity. And this we would call a grade 0. This is a Haber-Meyer grade 3 because it's going to be associated with a subscap tear. All righty, I'm getting tired of talking. Who's next? Okay, Roberto.
All right, so we have an axial. Looks like the biceps is perched and flattened.
Okay, so we have a perched biceps. So what are the next structures you have to look for?
Look at the subscap. There may be some partial tearing there.
Yeah, see some kind of interstitial tearing. Maybe goes down to the deep surface here.
Mm-hmm.
Okay. Superior ligament is intact in this case.
Yep.
And the supraglenohumeral ligament's abnormal. That's on 9/19/2012. This is a Haber-Meyer grade 3. Okay, so this is 12. Now the patient comes back and 12/4/21. What do you see here?
Now it looks like that biceps tendon looks thinner and it looks like it's anteriorly dislocated, displaced.
Okay. And then if we go farther down, how did you know it was thin?
Just look.
Here's thin. We've got increased interstitial tearing in the subscap right there. And so this is a progressive injury.
Yeah.
As I talked about before, and as John has confirmed from the orthopedic standpoint, these tend to be very symptomatic lesions. And as I said before, prior to MR, these are very difficult to diagnose, even at surgery. And but now this is something that you really have to look for. Okay.
All right, 60-year-old radiologist presents with cuff tear, but no anterior pain. All right.
4/23/08. Oh, 03. I'm sorry, 4/28/03.
Okay, so the subscapularis tendon is quite attenuated, at least tendonosis, maybe some interstitial tearing.
Maybe a little thickened and a little increased sigmotism, maybe tendonosis. The fibers are a little bit indistinct here.
Yeah,
So I agree with it's probably not normal. Biceps,
it's
not too bad.
yeah, not too bad.
Okay, so that's 03. This is 09.
All right, so it looks like the biceps tendon is perched upon the lesser tuberosity, and then you have at least moderate.
He was hoping that exercising would help his golf game. I later assured him that it wouldn't. So now he has anterior shoulder pain that he didn't have before.
Yeah. So yeah, biceps is perched on the lesser tuberosity. There's a interstitial tearing of the subscap adjacent, and that ulnar bursitis.
And to blow these up, here's a symptomatic shoulder, and here's really no symptoms in this location on the prior study. Okay, so that's really type 1 or perched biceps. Okay.
Okay, so
You
here,
usually have a tear of the rotator cuff when you have a pathology of the biceps.
Yeah.
So always look. Usually the patients come in for a rotator cuff tear, and then this is found.
Right.
I think that's the way it is, isn't it, John?
Yeah, I think most of the time, most clinicians are thinking rotator cuff tear, though
Yeah.
Orthopedic surgeons are usually much more accurate in their clinical suspicions. But again, we get a lot of cases not from orthopedic surgeons.
One thing that's interesting is that the biceps does not slide up and down the bicipital groove. It's
Right.
stationary.
Right,
Because
it's
if
extensive.
if it went up and down, it would be a problem right from probably 2 years of age. By then, you're already having problems. Uh, so the biceps tendon does not move in a groove
Right, it's
except
fixed to
from
the,
lateral to medial.
it's fixed in the glenoid, and it's used to tether the biceps so the biceps can then flex the elbow. Okay, and it's actually a very strong rotator of the forearm too. Okay,
But a very, very sensitive tendon.
Okay, so here, looking at the bicipital groove looks irregular, looks widened.
yeah.
There's some perching of the long head of the biceps. There's a tear, delaminating tear of the subscap.
So again, perched biceps, this is a chronic problem because you can see it's eroding the lesser tuberosity here where it's unstable.
A 56-year-old male with acute worsening of chronic anterior shoulder pain. So we have an axial view. It looks like the where the bicipital groove is like scalloping
Yeah.
along the,
So there are
Uh,
two bicipital grooves here.
and then so I did,
The
well,
root,
it's moved from the normal groove to its own new groove.
right. And then what else do you see?
looks like looks like there's some subscapularis tendonosis or okay, partial tearing,
Yeah.
and then
Okay, so this is an arthrogram. What else do you see here?
arthrogram. So I see the contrast within the joint space.
Right,
And
contrast in joint space. And what we see here is fluid in the subacromial subdeltoid bursa and the
not-
subcork here, which
There's
is not
communicating,
communicating at this
so-
time, right? Okay, so it's a chronic grade 1. Why don't we stop here?
I'm not sure about this grading. That's totally outside the normal groove.
Yeah. Yeah, so this
So
is, yeah, I'm sorry, this is,
I don't like these grading systems.
okay. So here we have a perched biceps that's not yet displaced into the subscapularis. So why don't we stop here? Because now we're going to go through progressive disease of the biceps. And I think we'll start from this grade 1. So this would be my grade 1. This would actually be a Habermeyer grade 3, right? Or maybe we'd have to see the supraspinatus. It could be a Habermeyer grade 4. Okay, and this is chronic. So let's stop here, and we'll pick up here tomorrow, and get through the biceps tomorrow, and maybe go on to another one. Okay, thanks.
Thank you.
Have a good one, gentlemen.
Okay, thanks, John.
See you mañana. Thank you, John.
Thank you, John.